Welcome back to the Deep Dive. Today, we're facing quite a stack of source material, really digging deep into a fascinating and honestly pretty complex area of pharmacology.
That's right. We're talking about anticholinergic drugs and also agents acting on the autonomic ganglia.
And the goal here, based on what our listener shared, isn't just, basic familiarity. It's about achieving real professional level mastery.
Exactly. We want to get beyond just memorizing lists of drugs and side effects. The aim is to understand the why. Why do these drugs act the way they do? It all comes back to the receptors, the underlying science.
Understanding that mechanism is crucial for clinical fluency.
Absolutely. If you grasp the receptor science, you can predict the effects, understand the side effects, and really know why you'd choose one agent over another.
Okay, so let's start with definitions. When we say anticholinergic, what are we primarily focusing on here?
Good starting point. Generally, in pharmacology, anticholinergic refers specifically to muscarinic receptor antagonists. Think atropine and related drugs. They're also called parasympathetics because they block the parasympathetic nervous system's effects mediated by acetylcholine at these muscarinic receptors.
And we need to keep that separate from the other types of acetylcholine blockers.
Yes, definitely. We need to distinguish them from nicotinic antagonists. Those fall into two main groups: the ganglion blockers, which act on autonomic ganglia, and the neuromuscular blockers, which act at the skeletal muscle junction. We'll touch on the ganglia later, but our main focus initially is these muscarinic blockers.
Got it. And you mentioned receptors being key. Can you quickly map out the important muscarinic subtypes for us, the ones that really drive the clinical picture?
Sure. There are 5 main subtypes, M1 through M5, but clinically we're mostly concerned with M1, M2, and M3. Their locations really dictate everything.
So where do we find them?
Okay, so M1 receptors, you find those mainly in the CNS, in the autonomic ganglia themselves, which is an interesting bit of modulation we'll get back to, and also on gastric parietal cells involved in acid secretion.
M1, CNS, ganglia, stomach acid. Okay. M2.
M2 is predominantly in the heart. It's the receptor responsible for the parasympathetic slowing of the heart rate. Critically, M2 receptors are also found as autoreceptors on presynaptic nerve endings. That's a super important concept.
Autoreceptors, like a feedback loop.
Exactly. They sense the neurotransmitter released by the nerve itself and usually act to inhibit further release. We'll see how blocking those causes some interesting effects.
Okay, M2, heartbreak and autoreceptor, and M3.
M3 is all about smooth muscle contraction. Think bronchial airways, the bladder, and also stimulating glandular secretions, salivary glands, sweat glands, bronchial glands. M3 is the target there.
Perfect. M1, M2, M3, CNS ganglia, stomach, heartoreceptor, smooth muscle glands. That's our map. So let's introduce the classic prototype drug.
Atropine. It's the archetypal anticholinergic, the one everything else is compared to.
And the core mechanism for atropine, and really the whole class.
It's straightforward but powerful. Competitive antagonism. These drugs physically bind to the muscarinic receptor, occupying the same site that acetylcholine normally would, but they don't activate it. They just block acetate from doing its job.
They compete for the parking spot, basically.
That's a good way to put it. And they're remarkably selective for muscarinic receptors, especially at therapeutic doses.
How selective are we talking?
Well, the early experiments, like using isolated guinea pig gut tissue, showed this clearly. Atropine potently blocks contractions caused by adding acetylcholine. But if you make the muscle contract using something else, like histamine or serotonin, atropine doesn't touch it.
So it really zeroes in on that H-muscarinic interaction.
Precisely. You only start to see effects on other receptors, like nicotinic ones, at extremely high toxic doses.
Okay, let's begin our system-by-system tour with atropine. Where does this powerful stuff come from originally?
It's straight from nature. These are alkaloids found in plants of the Solanaceae family. We're talking about plants like deadly nightshade, Atropa belladonna, and also Datura stramonium, Jimson weed.
Nature packing a punch. And chemically, atropine itself.
Atropine is actually a racemic mixture, meaning it contains equal parts of 2 mirror image isomers, D-hyoscyamine and ioscyamine. But here's the thing. The biological activity almost entirely resides in the LAVO, or L isomer. L-ioscyamine is much, much more potent than the D form.
And that relates to hyoscine.
Exactly. Hyoscine, also known as scopolamine, is actually pure L-hyoscine. That structural difference and differences in how they cross membranes explains their distinct profiles, especially in the brain.
Right. Let's get into the central nervous system effects. This is where atropine and hyoscine really diverge. What's atropine's general action in the CNS?
Atropine is generally considered a CNS stimulant. It can stimulate various centers in the medulla, the vagal center, respiratory center, vasomotor center.
But you don't usually see those effects with a standard dose, right?
Correct. At typical therapeutic doses, the peripheral effects like dry mouth or increased heart rate dominate. The reason is the blood-brain barrier, the BBB. Atropine is a tertiary amine, so it can cross, but its entry is somewhat restricted. You need higher doses to get significant amounts into the brain to cause obvious central stimulation.
Okay, now contrast that with hyoscine.
Hyoscine is different. It penetrates the BBB much more readily, even at low doses. So with hyoscine, the central effects are much more prominent, and they're actually depressant.
Depressant, how so?
Think drowsiness, fatigue, amnesia, a reduced ability to form new memories, and it can even induce a state resembling NREM sleep. It calms things down centrally.
And this difference in BBB crossing is key for clinical use.
Absolutely. It's precisely why hyoscine is far superior to atropine for treating motion sickness. That effect relies on central actions.
Let's touch on that anti-motion sickness effect.
Yeah.
How do they work there?
Well, both drugs do depress vestibular excitation. That's the input from your inner ear's balance system that triggers nausea when it gets overstimulated or mismatched with visual input. The exact site isn't perfectly clear, but it's thought to involve blocking cholinergic pathways linked to the vestibular system, maybe within the brainstem or even at the cortical level where that sensory information is processed. Hyoscine is just much better at getting to those central sites.
Makes sense. What about other central effects? Parkinsonism comes to mind.
Yes, that's a classic application. In Parkinson's disease, there's an imbalance in the basal ganglia, a relative deficiency of dopamine, and a resulting overactivity of acetylcholine. Using anticholinergic drugs like atropine congeners helps to block that excessive cholinergic activity.
Rebalancing the system a bit.
Exactly. It primarily helps with the tremor and rigidity components of Parkinsonism. It was a mainstay treatment before levodopa became available and is still used sometimes as an adjunct.
Now, what happens if atropine doses get too high? The CNS effects become dangerous then.
Oh, absolutely. This is atropine poisoning or belladonna poisoning. High doses cause significant cortical excitation. The person becomes restless, agitated, disoriented. They can experience vivid, often terrifying hallucinations and delirium.
Scary stuff.
Very. And if the dose is high enough, this excitation phase is followed by profound central depression, respiratory depression, cardiovascular collapse, coma, and potentially death.
A critical toxicity profile to understand. Okay, let's pivot to the cardiovascular system. This is where things get particularly interesting, especially with that vagal paradox.
Right. The main expected effect of atropine on the heart is tachycardia, an increase in heart rate.
And the mechanism there is straightforward.
Pretty much. It's blocking the M2 receptors on the SA node, the heart's pacemaker. Acetylcholine via the vagus nerve normally acts on these M2 receptors to slow the heart down. Atropine blocks this brake, so the heart rate increases.
And the effect depends on the person's baseline vagal tone.
Exactly. Young, healthy adults tend to have higher vagal tone, meaning their baseline heart rate is more strongly influenced by parasympathetic input. So in them, atropine causes a more pronounced tachycardia compared to, say, infants or the elderly who might have lower vagal tone.
Okay, that's the standard effect. But now for the nuance, the mastery point. That initial bradycardia, what's happening there?
This is fascinating, often particularly with rapid intravenous injection. Before the tachycardia kicks in, there's a brief transient slowing of the heart rate, a bradycardia.
Which seems counterintuitive if you're blocking the slowing effect.
Totally counterintuitive based on just M2 blockade. The older explanation was that maybe atropine initially stimulated the vagal center in the medulla before the peripheral blockade took over.
But the source material points to a different, more accepted mechanism now.
Yes, the current understanding focuses on those M1 autoreceptors we mentioned earlier, located on the vagal nerve endings themselves, right near the SA node.
Remind us how those work.
Okay, when the vagus nerve fires and releases acetylcholine, ACH, some of that AC binds to these M1 autoreceptors on the same nerve terminal. This binding acts as a negative feedback signal. It tells the nerve, okay, enough AC released, and inhibits further release.
A self-regulating brake on HC release.
Precisely. Now imagine injecting atropine. It's non-selective, so it blocks all muscarinic receptors it encounters. The idea is that it might block these easily accessible M1 autoreceptors first, or perhaps they're just more sensitive to low concentrations.
And blocking the M1 autoreceptor.
Means you block the negative feedback. You cut the brake line for AC release itself. So for a brief moment, the vagal nerve terminal actually releases more AC than usual.
Ah, so you get a temporary surge of AC hitting the M2 receptors on the SA node.
Exactly. That transient surge of AC causes the brief bradycardia before the rising concentration of atropine fully blocks the M2 receptors on the heart muscle itself, leading to the dominant tachycardia effect.
That makes so much more sense than the central stimulation theory. Is there good evidence for this M1 mechanism?
Yes. For one, drugs that selectively block M1 receptors, like parasympathetic, can also cause this initial bradycardia, even though parasympathetic doesn't significantly block M2 receptors in the heart. Also, quaternary anticholinergic drugs, which cannot cross the blood-brain barrier, can still cause the initial bradycardia, which argues against a central mechanism.
Okay, that M1 autoreceptor blockade causing transient AC surge, that's a key piece of advanced understanding. Beyond heart rate, what about conduction?
Atropine also affects the AV node, the electrical relay station between the atria and ventricles. It shortens the refractory period of the AV node cells and generally speeds up conduction through the node. This shortens the PR interval on an ECG.
Useful in certain situations.
Yes, particularly if AV conduction is slowed down due to high vagal tone, which can happen sometimes after a heart attack or with certain drugs. Atropine can help improve that conduction.
And blood pressure. We often think of vascular tone being mostly sympathetic.
That's largely true. Baseline vascular tone isn't really maintained by cholinergic nerves, so atropine usually has an inconsistent or minimal effect on overall blood pressure.
But there are competing factors.
Right. The tachycardia it causes might tend to slightly raise blood pressure. On the other hand, at very high toxic doses, atropine can cause histamine release or even have a direct slight vasodilator effect, which would tend to lower blood pressure. So the net effect is usually small.
But it would block the effect of a cholinergic drug on blood pressure.
Oh, definitely. If you gave a drug like acetylcholine or methacholine, which causes profound vasodilation and a drop in blood pressure, atropine would effectively block that vasodepressor response.
Got it. Finally, for atropine's systemic effects, let's look at the eye. This is a classic anticholinergic target.
Extremely sensitive. When applied topically like eye drops, atropine causes profound effects. First, mydriasis dilation of the pupil. This happens because it blocks M3 receptors on the pupillary sphincter muscle, which normally constricts the pupil. Blocking it lets the opposing radial muscle, under sympathetic control, pull the pupil open.
And it wipes out the light reflex.
Completely abolishes it because that reflex relies on the sphincter muscle constricting. Second, it causes cycloplegia.
Paralysis of...
Paralysis of the ciliary muscle. This muscle controls the shape of the lens for focusing. Blocking its M3 receptors paralyzes it, fixing the lens for far vision and making near vision blurry.
And the real kicker with atropine drops is the duration.
It's incredibly long. The mydriasis and cycloplegia can last for 7 to 10 days. This leaves the patient with significant photophobia sensitivity to light because the pupil can't constrict and blurred near vision for a whole week or more. It's quite disabling.
And the big risk associated with dilating the pupil.
The risk is increasing intraocular pressure, especially in individuals predisposed to narrow-angle glaucoma. Dilating the pupil can bunch up the iris tissue in the angle where a fluid normally drains from the eye, potentially blocking drainage and causing a dangerous spike in pressure.
But this is mainly with topical use. Systemic doses are less risky for the eye.
Generally, yes. Systemic doses usually don't achieve high enough concentrations in the eye to cause such dramatic or prolonged effects, although some blurring or mild dilation can occur.
Okay, let's move on to atropine's effects on smooth muscles in other parts of the body. Again, mostly M3-mediated relaxation. Let's start with the gut.
Right. In the gastrointestinal tract, atropine relaxes the smooth muscle in the walls of the stomach and intestines. This reduces the overall tone and decreases the amplitude and frequency of contraction.
It slows things down.
Yes, it slows the passage of food and residue through the gut. This can be useful for relieving spasms, like in irritable bowel syndrome, but the flip side is it can cause constipation.
But the sources mention that peristalsis isn't completely stopped by atropine. Why is that?
That's a crucial point about gut physiology. While the vagus nerve provides major extrinsic cholinergic input that atropine blocks, the gut has its own extensive intrinsic nervous system, the enteric nervous system.
The second brain.
Pretty much. Peristalsis is heavily controlled by local reflexes within this intrinsic system, and these reflexes use a whole host of neurotransmitters besides acetylcholine, things like serotonin, nitric oxide, various peptides like enkephalins. Atropine only blocks the cholinergic component, leaving these other local control mechanisms largely intact. So motility is reduced but not abolished.
Makes sense. What about the urinary tract?
Similar principle. M3 blockade relaxes the smooth muscle of the ureters and, importantly, the detrusor muscle in the wall of the urinary bladder.
Leading to the well-known side effect.
Urinary retention. By relaxing the bladder wall, it makes it harder to empty the bladder effectively. This is particularly a problem in older men who might already have some outflow obstruction due to an enlarged prostatic hypertrophy.
But again, this side effect can be turned into a therapeutic benefit.
Exactly. This bladder-relaxing effect, sometimes called a vasicoselective action, though that term is usually for drugs more selective for the bladder, is used therapeutically. We use anticholinergics to treat conditions of bladder overactivity, like detrusor hyperreflexia in neurogenic bladder, or urge incontinence, or even sometimes bedwetting and uresis in children. The goal is to increase the bladder's storage capacity and reduce unwanted contractions.
And this need led to developing more bladder-specific drugs, which we'll get to. What about the airways, the bronchial muscles?
M3 blockade here causes bronchodilation relaxation of the smooth muscle surrounding the airways. This reduces airway resistance, making it easier to breathe.
Particularly relevant in certain conditions.
Yes, especially in chronic obstructive pulmonary disease, COPD, and to some extent in asthma. In these conditions, there's often an increased vagal tone or reflex bronchoconstriction, partly driven by inflammation. Anticholinergics help by blocking this cholinergic component.
Though maybe not the first choice for an acute asthma attack.
Generally, no. The beta-2 agonists, like albuterol, provide faster and often more potent bronchodilation for acute relief. Anticholinergics are often better for maintenance therapy, particularly in COPD, targeting that underlying vagal contribution.
Okay, moving from smooth muscle to glands and secretions. This is probably the most universally recognized anticholinergic effect.
The drawing effect, absolutely. M3 receptors are critical for stimulating secretions from various glands. Blocking them with atropine causes a marked decrease in secretions.
Which ones are most affected?
Saliva production drops dramatically, leading to dry mouth, xerostomia. Sweat production is inhibited, leading to dry, warm skin. Tear production decreases, causing dry eyes, and tracheobronchial secretions are reduced.
Making it hard to talk or swallow sometimes.
Yes, the lack of saliva makes swallowing difficult, and the dry airways can be uncomfortable.
What about gastric acid secretion? We mentioned M1 receptors earlier.
Atropine can reduce gastric acid secretion, along with pepsin and mucus volume. However, it takes relatively higher doses to achieve this compared to the doses needed to dry up saliva, for example. And importantly, its effectiveness in reducing acid is much less than that of H2 blockers, like ranitidine historically, or proton pump inhibitors, PPIs like omeprazole.
So, not a primary anti-ulcer drug anymore. Are other digestive secretions affected?
Not significantly. Intestinal secretions, pancreatic juice, bile, these are not primarily under cholinergic control, so atropine doesn't really reduce them. Again, highlighting the specificity of autonomic control.
Okay, one last systemic effect. Body temperature.
Right. At higher doses, atropine can cause a rise in body temperature, sometimes called atropine fever.
Why does that happen? Is this just the lack of sweating?
That's the main reason. Sweating is a crucial mechanism for cooling the body, especially in warm environments or during exertion. By inhibiting sweating, an M3 effect on sweat glands, even though they are innervated by sympathetic cholinergic nerves, atropine prevents this heat loss. There might also be a secondary minor contribution from direct stimulation of the temperature-regulating center in the hypothalamus at very high doses.
And children are more susceptible?
Yes, children, especially infants, are particularly prone to atropine fever. Their thermoregulatory system is less mature, and they have a higher surface area to body mass ratio, making them more sensitive to changes in heat dissipation.
Okay, we've covered the major systems. Now let's synthesize this into a core concept for mastery. The sensitivity gradient. Not all organs react equally to the same dose of atropine.
This is absolutely critical for understanding clinical effects and side effects. Different organs and functions show vastly different sensitivities to muscarinic blockade.
So which functions are the most sensitive? Hit hardest by the lowest doses?
The highest sensitivity belongs to salivary glands, sweat glands, and bronchial secretions. Their function is highly dependent on cholinergic input. Even a small dose of atropine will noticeably dry your mouth or skin.
That makes sense. Those are often the first side effects people notice. What's in the medium sensitivity range?
Here we find the eye, causing pupil dilation and impacting accommodation, the smooth muscle of the bronchi, causing bronchodilation, and the heart, causing tachycardia. These require a moderate dose to see significant effects because while cholinergic input is important, there's often more counterregulation or other factors involved.
And finally, the least sensitive targets, the ones needing the highest doses.
These are the smooth muscle of the GI tract, reducing motility, and the urinary bladder, causing relaxation retention, and the gastric glands, reducing acid secretion.
Why are they least sensitive?
It boils down to their relative dependence on cholinergic tone versus other control mechanisms. As we discussed with the gut, there's strong intrinsic control. Gastric acid secretion is driven by multiple pathways: histamine, gastrin. The bladder has complex regulation, so blocking only the cholinergic input has a less dramatic effect unless the dose is quite high. Also, factors like the density of receptors or the width of the synaptic gap might play a role in accessibility.
Understanding this gradient, saliva, sweat, bronchial secretions, eye, bronchial, muscle, heart, gut, bladder, gastric glands, is key to predicting which effects appear first and which require higher doses.
Precisely. It explains the typical sequence of side effects as the dose increases.
That sensitivity gradient and the desire to avoid widespread side effects naturally led to the search for alternatives to atropine. But first, let's quickly compare atropine with the other major natural alkaloid, hyoscine, scopolamine, based on that source table comparison.
Right. They differ significantly. Source: atropine, mainly from Atropa belladonna or datura, hyoscine from Hyoscyamus niger. CNS effect at low dose. Atropine tends towards mild excitation, though often not apparent, whereas hyoscine is clearly depressant, drowsiness, amnesia.
And potency differences.
Yes. Atropine is generally more potent on the heart, tachycardia, bronchial muscle, and intestines. Hyoscine, on the other hand, is more potent on the eye, mydrius cycloplegia, and secretory glands, drying effect.
And the big one for clinical use.
Motion sickness. Hyoscine is vastly superior. The table rates it plus compared to maybe plus for atropine. Pharmacokinetics also differ. Hyoscine crosses the BBB much better and is metabolized more completely.
Okay, so distinct profiles even among the natural compounds. Now let's talk about the synthetic modifications, starting with the quaternary compounds. What's the key structural feature here?
These compounds have a nitrogen atom with 4 bonds, giving it a permanent positive charge. Think of drugs like ipratropium, tiotropium, hyoscine, butyl bromide.
And what does that permanent charge do pharmacologically?
It fundamentally changes how the drug behaves in the body. Because they are charged ions, they are very poorly lipid-soluble. This has 3 major consequences. 1, poor oral absorption. They don't easily cross the gut wall, so only maybe 10–30% of an oral dose gets into the bloodstream.
2,
poor penetration across barriers like the blood-brain barrier and into the eye. So when given orally or by injection, they cause minimal or no CNS effects and minimal ocular effects.
Well,
This is a huge advantage if you want purely peripheral action.
and a 3.
3, they tend to be eliminated differently and often have a longer duration of action compared to their tertiary amine counterparts.
So you trade oral absorption for peripheral selectivity and duration. Is there a downside to the quaternary structure?
Yes, there's a potential trade-off. That quaternary structure sometimes increases the drug's affinity for nicotinic receptors in addition to the muscarinic ones. Meaning that at therapeutic doses, or especially slightly higher ones, they might start to cause some degree of ganglionic blockade blocking transmission at the autonomic ganglia.
And the symptoms of ganglionic blockade would be?
Things like postural hypotension, dizziness on standing up due to blocked sympathetic tone to blood vessels, potentially impotence. At very high doses, they could even cause some neuromuscular blockade at the skeletal muscle junction, though that's less common clinically.
Okay, let's look at key examples. The inhaled ones are huge. Ipratropium bromide.
A cornerstone of COPD therapy. Being quaternary and given by inhalation, it stays largely within the lungs. It blocks M3 receptors on bronchial smooth muscle, causing bronchodilation.
Why inhalation?
To maximize local effects in the airway and minimize systemic absorption and side effects like dry mouth or blurred vision, its onset is slower than beta agonists, making it better for maintenance than acute rescue.
And critically, compared to systemic atropine for breathing.
It does not dry out or thicken bronchial secretions significantly, and it doesn't impair mucociliary clearance, the escalator mechanism that clears mucus from the lungs. This is a major safety advantage over older systemic anticholinergics for respiratory use. It acts mainly on the larger airways where vagal control is strong.
Then came tiotropium bromide. What makes it different? Better for long-term COPD.
Tiotropium is kind of a super epitropium for maintenance. It binds very tightly, especially to M1 and M3 receptors in the lung, giving it a very long duration of action, 24 hours or more. This allows for convenient once-daily dosing.
And there's a nuance about its receptor binding profile, something about M2.
Yes, this is quite sophisticated. Remember the M2 autoreceptors on airway nerves that inhibit ACE release. Tiotropium binds much less tightly, or dissociates more quickly, from these M2 receptors compared to M1 and M3.
Why is that good?
Because if you potently block the M2 autoreceptor, you might actually increase local ACE release, potentially counteracting some of the M3 blockade or even causing a transient bronchospasm. By sparing the M2 receptor relative to M3, tiotropium achieves potent, long-lasting bronchodilation M3 block with less risk of this paradoxical effect. It gives it a degree of functional M1, M3 selectivity in the airways.
Quaterary pharmacology. What about quaternary drugs used for gut spasms?
Hyoscine butyl bromide is a common one used for abdominal cramps or spasms. Again, being quaternary, it acts peripherally on the gut smooth muscle with minimal systemic side effects. Propantholine and oxyphenonium were older ones used for peptic ulcers and gut hypermotility, but they've largely been replaced by much more effective drugs like H2 blockers and PPIs.
Okay, let's switch from quaternary back to tertiary amines, but one's designed for more specific targets. Dicyclomine is interesting.
Dicyclomine is a bit unusual. It's a relatively weak anticholinergic with some M1 selectivity, but it also has a direct relaxant effect on smooth muscle, independent of blocking ACE.
A dual mechanism.
Yes. This makes it useful for things like irritable bowel syndrome, IBS, intestinal colic, and even dysmenorrhea, menstrual cramp. It also seems to have some antiemetic properties used sometimes for morning sickness or motion sickness, though less effective than hyoscine.
But there's a specific warning for dicyclomine.
A very important one, noted in the source. It should not be used in infants under 6 months old due to reports of serious respiratory distress, seizures, syncope, and even death. Its anticholinergic effects can be particularly dangerous in very young infants.
Good safety point. What about parasympathetic? We mentioned it regarding the M1 autoreceptor.
Parasympathetic was a landmark drug historically. It was the first relatively selective M1 blocker. Since M1 receptors are found in autonomic ganglia controlling the stomach and on the parietal cells themselves, it was developed to inhibit gastric acid secretion.
Did it work?
Yes, it did reduce acid secretion, and because it was M1 selective, it caused fewer of the typical anticholinergic side effects like dry mouth, blurred vision, or tachycardia, which are mainly M3 and M2 mediated. The thinking was it mainly acted on the nerve plexuses within the stomach wall.
But like the older quaternary drugs for ulcers.
It's been completely superseded by the far more potent and effective H2 blockers and PPIs. Still, it was important proof of principle for receptor subtype selectivity.
Now let's focus on a major area of development. The vasicoselective anticholinergics for the bladder.
Right. This is for treating overactive bladder, OAB, that constellation of symptoms like urinary urgency, frequency, and urge incontinence. The goal was to find drugs that relax the bladder, M3 blockade, with fewer systemic M3 side effects, especially dry mouth.
Oxybutynin was an early one.
Yes. Oxybutynin has a high affinity for muscarinic receptors in the bladder detrusor muscle and also salivary glands. It shows some relative selectivity for M3 and M1 subtypes. It's quite effective at increasing bladder capacity and reducing urgency.
But the side effect issue.
Dry mouth is very common and often dose-limiting because it hits salivary M3 receptors hard too. This is a major reason patients stop taking it.
And a crucial point from the source about its metabolism.
Absolutely critical for safety. Oxybutynin is metabolized primarily by the liver enzyme CYP3A4. This means if a patient is taking another drug that strongly inhibits CYP3A4, common examples include certain antifungal drugs like ketoconazole or antibiotics like clarithromycin, the levels of oxybutynin can shoot up dramatically, leading to severe anticholinergic toxicity. Dose reduction is often needed.
A key interaction to watch for. Did newer drugs improve on oxybutynin?
That was the goal. Polterodin was developed next. It also targets M3 receptors, but was designed to have a somewhat more preferential action on the bladder compared to salivary glands.
Meaning less dry mouth.
Theoretically, yes, or at least less dry mouth for a comparable degree of bladder effect in some patients. Though dry mouth is still a common side effect. Tolterodin is also metabolized by CYP enzymes, mainly CYP2D6, but also 3A4, so similar interaction potentials exist.
And the even newer ones like darafenacin and sulfonacin.
These are generally considered even more M3 selective, further trying to target the bladder while sparing salivary glands and other M3-mediated functions. They also tend to have long biological half-lives. Darafenacin in its extended release form lasts 13-19 hours, allowing for once-daily dosing, which helps with compliance. They are mainstays now for OAB.
Okay, we've seen the individual drugs. Let's pull it together and summarize the main clinical applications, starting with antisecretory uses.
The classic use is pre-anesthetic medication. Historically, when volatile anesthetics like ether were used, they were very irritating and caused excessive respiratory secretions and saliva, risking airway obstruction or laryngospasm. Atropine or glycopyrrolate, a quaternary agent, was essential to dry these up.
Is it still used now with modern, less irritating anesthetics like halothane or sevoflurane?
Yes, often it still is, though maybe less universally. One reason is that anesthesia and surgery can sometimes cause vagal reflexes leading to bradycardia. Having atropine on board or readily available helps counteract this. It also still helps reduce the already lower secretions, potentially preventing reflex laryngospasm during airway manipulation.
Any other antisecretory uses?
It can be used in conditions like pulmonary embolism where there might be reflex increases in bronchial secretions, although that's not a primary treatment.
All right, what about antispasmodic uses? Relieving muscle spasms.
Anticholinergics, especially the peripherally acting ones like hyoscine butyl bromide or dicyclomine, are used for symptomatic relief of spasms in the GI tract, like an irritable bowel syndrome or intestinal colic. They can also provide some relief in renal colic by relaxing the ureter.
But maybe not the main treatment for kidney stone pain.
No. For the intense pain of renal colic, opioids or NSAIDs are generally much more effective at managing the pain itself, although the anticholinergic might help slightly with the spasm component.
And the major antispasmodic use we discussed is for the bladder.
Definitely. The vasicoselective M3 antagonists, oxybutynin, tolterodine, sulfonacin, darafenacin, are first-line treatments for overactive bladder symptoms. Urinary frequency, urgency, and urge incontinence, including conditions like neurogenic bladder or aneresis, they work by relaxing the overactive detrusor muscle.
But always with that caveat about dry mouth limiting therapy.
Always. It's the most common reason people stop treatment.
Okay, let's revisit the bronchial applications, specifically for COPD and asthma, hammering home the route of administration.
This is crucial. Orally administered atropinic drugs are basically obsolete for respiratory conditions.
Why obsolete?
Two main reasons. First, you need high systemic doses to get enough drug to the lungs, leading to significant side effects, dry mouth, blurred vision, etc. Second, and more importantly, systemic anticholinergics can dry out bronchial secretions, make them thick and tenacious. That's called inspissation, which can impair mucociliary clearance and actually worsen airway obstruction or increase infection risk.
So the solution is inhalation.
Exactly. Inhaled ipratropium and tiotropium revolutionized this. By delivering the drug directly to the airways, you get effective bronchodilation with minimal systemic absorption and without that dangerous drying effect on secretions.
How effective are they?
Very effective, particularly in COPD, where reflex vagal activity is often a major component of the bronchoconstriction. They are suitable for regular prophylactic use because their onset is gradual. Tiotropium, being long-acting, once daily, is particularly good for maintenance therapy and has been shown to reduce the frequency of COPD exacerbations.
Can they be used in acute situations?
Yes, especially ipratropium. In acute exacerbations of COPD or severe asthma, it's often given via nebulizer, frequently in combination with a short-acting beta-2 agonist like albuterol, to achieve maximal bronchodilation through attacking the spasm via both cholinergic and adrenergic pathways.
Okay, now for the mydriatic and cycloplegic uses in ophthalmology. Let's start with diagnostics. For refraction testing, measuring someone's prescription for glasses.
You need both mydriasis, pupil dilation, to see the back of the eye properly, and cycloplegia, paralysis of focusing, to relax the eye's natural accommodation, which can interfere with getting an accurate measurement, especially in younger people.
But atropine itself is usually too much for this.
Way too much. That 7-10-day duration of blurred vision and light sensitivity is just not practical for routine testing. So, shorter acting agents are preferred.
Like which ones?
For adults, tropicamide is often the first choice. It's the quickest acting, starts working in 20-40 minutes, and has the shortest duration. Effects wear off in about 3-6 hours. It provides good mydriasis, sometimes augmented with phenylephrine and alpha agonist mydriatic, and decent cycloplegia for many adults.
What if you need stronger cycloplegia?
Then cyclopentolate is often used. It takes a bit longer to act, 30-60 minutes, and lasts longer, about 24 hours. But it provides more reliable paralysis of accommodation, making it better for cycloplegic refraction, especially in older children or younger adults.
You mentioned children. Is atropine ever used for refraction?
Yes, in young children, say under 5 years old. Their accommodative ciliary muscle is so strong that tropicamide or cyclopentolate might not be enough to fully relax it. In those cases, atropine eye ointment, usually 1%, might still be needed over a few days to ensure complete cycloplegia for an accurate reading.
What about just needing to look at the fundus, the back of the eye, without doing a full refraction?
For routine fundoscopy, you primarily just need mydriasis, pupil dilation. You don't necessarily need the cycloplegia. In this case, a short-acting antimuscarinic like tropicamide can be used, or often, especially in older adults, the alpha agonist phenylephrine is preferred. Phenylephrine dilates the pupil without paralyzing accommodation, which reduces the risk of blurring near vision and, importantly, has less risk of precipitating angle closure glaucoma.
Okay, that's diagnostics. What about therapeutic uses of atropinics in the eye?
Here, the long duration of atropine can actually be an advantage. It's used in inflammatory conditions like iritis, iridocyclitis, inflammation of the iris and ciliary body, or keratitis, corneal inflammation.
Why is it useful there?
Several reasons. The cycloplegia rests the inflamed intraocular muscles, iris sphincter and ciliary muscle, which reduces pain. The mydriasis helps prevent the inflamed iris from sticking to the lens behind it, forming posterior synechia. If adhesions have already formed, the strong, prolonged dilation from atropine can sometimes help break them. It also seems to have a local analgesic effect on the cornea.
So you might alternate it with something else.
Sometimes, to help break adhesions, clinicians might alternate atropine to pull the iris away from the lens with a miotic agent, like pilocarpine, to constrict the pupil and pull it away from the periphery.
Got it. Let's cover the special uses, cardiac and central. Cardiac uses.
Atropine is the go-to drug for treating symptomatic sinus bradycardia, slow heart rate causing symptoms like dizziness or fainting, or partial heart block like Mobitz aria or Venkabach, where the underlying cause is excessive vagal tone. This can happen after a heart attack due to certain medications like digitalis or sometimes just spontaneously.
But there's a risk.
Definitely. Increasing the heart rate in someone with an already compromised or ischemic heart could potentially worsen the ischemia or precipitate ventricular arrhythmias. It needs careful use and monitoring.
Central uses motion sickness we covered. Hyoscine is king.
By far the most effective drug, usually given as a 0.2 milligram tablet orally before travel, lasting 4-6 hours. The transdermal patch behind the ear is also very popular, providing protection for up to 3 days.
Main side effects to warn patients about.
Drowsiness and dry mouth are very common with hyoscine due to its CNS penetration. Patients need to be cautioned about driving or operating machinery.
And finally, atropine as an antidote.
Crucial role here. It's the specific antidote for poisoning by anticholinesterase agents, things like organophosphate insecticides or nerve gases, and also for poisoning by certain types of mushrooms that contain muscarine.
Why does it work?
These poisons cause a massive buildup of acetylcholine by inhibiting the enzyme that breaks it down, acetylcholinesterase. This leads to overwhelming stimulation of muscarinic receptors throughout the body. The SLEGE syndrome, salivation, lacrimation, urination, defecation, GI upset, emesis, plus bradycardia, bronchospasm. Atropine competitively blocks these receptors, counteracting the life-threatening effects. Large doses might be needed.
Is it used in other reversal situations?
Yes. When using an anticholinesterase drug like neostigmine therapeutically, for instance, to reverse the effects of neuromuscular blocking drugs after surgery, or to treat myasthenia gravis, or even in some snakebite protocols, neostigmine will also stimulate muscarinic receptors, causing unwanted side effects. So you co-administer atropine or glycopyrrolate to block those muscarinic effects while allowing neostigmine to have its desired effect at the nicotinic receptors, at the neuromuscular junction.
Okay, let's shift gears now from muscarinic antagonists to the autonomic ganglia and nicotinic pharmacology. The source material emphasizes the ganglion isn't just a simple switch.
Not at all. It's easy to think of it as just a relay station where the preganglionic nerve releases ASHI, it hits a nicotinic receptor on the postganglionic nerve, and the signal continues. That is the primary fast transmission pathway mediated by ASHI acting on the dominant nicotinic and subnessa neuronal type receptors, causing rapid depolarization.
But there's more going on. Modulation.
A lot more. That fast nicotinic transmission is heavily modulated by slower secondary events happening within the ganglion. These involve ASHI acting on muscarinic receptors, M1 and M2 subtypes within the ganglion, as well as input from other neurotransmitters released by interneurons, or even the preganglionic nerve itself. Things like dopamine, GABA, peptides, even norepinephrine can influence ganglionic excitability.
So it's a complex processing center, not just a relay.
Exactly. It integrates signals and fine-tunes the output of the postganglionic neuron.
This complexity helps explain the actions of nicotine, the main alkaloid in tobacco.
Right. Nicotine is an agonist. It activates both neuronal and and muscle type and nicotinic receptors, although its effects are much more prominent at the ganglia and CNS and receptors at typical doses from smoking.
So it stimulates both sympathetic and parasympathetic ganglia.
Initially, yes. That's why smoking has such widespread, immediate effects, increased heart rate and blood pressure, sympathetic stimulation, but also increased gut activity, parasympathetic stimulation. However, the other key property of nicotine is that at higher concentrations, or with persistent exposure, it causes persistent depolarization of the postganglionic neuron.
Meaning it keeps the receptor activated.
Yes, but the neuron can't repolarize properly to fire again. This leads to a state of functional blockade. So nicotine is initially a stimulant, but ultimately becomes a blocker at high doses.
Given this complexity, do drugs that just broadly stimulate ganglia have any use?
No therapeutic application whatsoever. Stimulating both sympathetic and parasympathetic systems simultaneously is chaotic and doesn't achieve any useful clinical goal.
What about drugs that block ganglia non-selectively?
Yeah.
Like trimethophan, which was mentioned.
Ganglionic blockers are now obsolete, primarily because their side effects are simply intolerable. Blocking all autonomic outflow causes widespread disruption.
Why were the side effects so bad? What does ganglionic blockade reveal?
It dramatically illustrates the concept of dominant autonomic tone. Most organs receive input from both sympathetic and parasympathetic divisions, but usually one division exerts the dominant influence on the organ's baseline function. When you block all autonomic input with a ganglionic blocker, the organ's function shifts dramatically, revealing which system was normally in charge.
Okay, let's use the examples from Table 8.2 in the source to see this. The heart.
The heart's baseline rate is primarily controlled by parasympathetic vagal tone, keeping it slow. Block the ganglia, remove the vagal brake, and you get severe tachycardia. So the heart is parasympathetic dominant for rate.
Blood vessels.
Arterioles and veins are predominantly under sympathetic control, maintaining vascular tone and blood pressure. Block the ganglia, lose that sympathetic tone, and you get massive vasodilation, leading to a sharp drop in blood pressure, especially on standing postural hypotension. So, blood vessels are sympathetic dominant.
The eye. Ciliary muscle and pupil.
These are under parasympathetic control for focusing, accommodation, and pupillary constriction. Block the ganglia, and you get mydriasis, dilated pupil, and cycloplegia, paralysis of accommodation. Parasympathetic dominant.
Sweat glands. These are anatomically sympathetic but functionally.
Functionally cholinergic. They release ASHI onto muscarinic receptors. They are considered sympathetic dominant in terms of outflow control. Blocking the ganglia leads to anhidrosis, inability to sweat.
What about the GI tract and bladder?
Both are largely parasympathetic dominant for motility and emptying. Ganglionic blockade causes severely reduced gut motility, potentially paralytic ileus, and urinary retention.
Salivary glands.
Also parasympathetic dominant for secretion, blockade causes profound dry mouth.
And sexual function.
This relies on a complex interplay of both divisions. Ganglionic blockade severely impairs both erection, parasympathetic role, and ejaculation, sympathetic role.
So the widespread, often dangerous side effects of ganglionic blockers basically map out the normal dominant control of each organ system.
Precisely. It's a powerful, if clinically unusable, demonstration of autonomic physiology.
Okay, let's connect this nicotinic pharmacology to a major clinical application. Smoking cessation. How do the therapies work?
There are three main pharmacotherapy strategies, all targeting the nicotinic system in different ways, aiming to reduce craving and manage withdrawal symptoms.
First line is often nicotine replacement therapy, NRT.
Right. The goal here is straightforward substitution. Provide nicotine through a safer delivery system, patch, gum, lozenge, to ease the physical withdrawal symptoms, the restlessness, irritability, anxiety, difficulty concentrating, tremors that happen when the brain is deprived of the nicotine it's used to.
How well does it work for craving?
It helps suppress the baseline craving and physical symptoms, especially the patch, which gives steady levels. However, NRT doesn't fully replicate the rapid high peaks of nicotine delivered to the brain by inhaling cigarette smoke. Those peaks are strongly linked to the reinforcing rewarding effects. So NRT often only partially reduces the psychological craving or the urge triggered by cues.
Does the delivery method matter?
Patch versus gum.
The patch provides smooth, continuous delivery, good for background withdrawal suppression. The gum, lozenge, or inhaler allows for more user-controlled, intermittent dosing, which some find more helpful for managing sudden urges, mimicking the act of smoking a bit more. Combining patch plus short-acting form is often more effective.
Okay, second strategy, varenicline, Chantix champix. This one's more sophisticated.
Very much so. Varenicline is a selective partial agonist at a specific subtype of nicotinic receptor, the S sub 4 sub 2 sub, alpha 4 beta 2 receptor.
And where is that receptor important? These S sub sub 2 subreceptors are highly concentrated in areas of the brain involved in the reward pathway, particularly the mesolimbic dopamine system, originating in the VTA and projecting to the nucleus accumbens. Nicotine's addictive power comes largely from its ability to stimulate these receptors, causing a surge of dopamine release, which feels pleasurable and reinforcing.
So how does varenicline as a partial agonist help someone quit?
It works in two ways. First, by being an agonist, even partially, it provides some stimulation to the A subreceptors, mimicking nicotine enough to reduce the severity of withdrawal symptoms and craving. That's the substitution part. Second, and crucially, because it's only a partial agonist, it doesn't cause the full dopamine surge that nicotine does, and importantly, it binds quite tightly to the receptor. So if the person does smoke while taking varenicline, the nicotine from the cigarette finds the receptors already occupied by varenicline and can't bind effectively. This blocks nicotine from causing its usual rewarding dopamine release. The cigarette becomes less satisfying.
So it both eases withdrawal and makes smoking less rewarding.
Exactly. That dual action is why it's generally considered one of the most effective single-smoking cessation medications, with efficacy often comparable to or slightly better than NRT or bupropion.
But it comes with significant side effect warnings.
Yes. Common side effects include nausea, insomnia, and vivid dreams. More seriously, there have been concerns and warnings about potential neuropsychiatric effects, changes in mood, depression, agitation, and even suicidal thoughts or behavior, although large post-marketing studies have somewhat lessened the perceived risk compared to initial concerns. Still requires careful patient selection and monitoring.
Okay, and the third pharmacotherapy option?
Bupropion, Zybanwellbutrin. This is actually an antidepressant medication, classified as an atypical antidepressant.
How does it help with smoking cessation?
Its primary mechanism is thought to be the inhibition of neuronal reuptake of dopamine and norepinephrine. By boosting dopamine levels, particularly in the reward pathway, it may mimic some of nicotine's effects and reduce craving and withdrawal. Its efficacy is generally rated as equivalent to NRT.
So 3 distinct pharmacological approaches. Replace nicotine, partially activate block the key receptor, or modulate dopamine or epinephrine pathways. Let's wrap up with the crucial aspects of safety: toxicity, contraindications, and interactions of the primary anticholinergic muscarinic antagonist drugs. First, side effects.
As we've stressed, the common side effects are really just the expected pharmacological actions occurring in organ systems you weren't targeting. Dry mouth, difficulty swallowing, dry or flushed or hot skin from reduced sweating, difficulty urinating, blurred near vision, sensitivity to light, photophobia, sometimes palpitations or tachycardia.
Are they usually serious?
In typical therapeutic doses, they're mostly annoying rather than dangerous, but they are very common and significantly impact patient compliance, especially dry mouth and blurred vision.
But overt poisoning is a different story. Belladonna, poisoning from atropine, or related plant drugs.
Yes, this is a medical emergency, and children are particularly susceptible. The signs are essentially exaggerated pharmacological effects gone wild.
You paint the picture, the classic description.
Hot as a hare, high fever due to inhibited sweating. Blind as a bat, dilated pupils unresponsive to light, severe blurred vision. Dry as a bone, intensely dry mouth and skin. Red as a beet, flushed skin due to vasodilation trying to shed heat. And mad as a hatter, the CNS effects. extreme restlessness, confusion, disorientation, vivid and often frightening hallucinations,
A
delirium.
very dramatic presentation. What happens if it progresses?
The excitation phase can be followed by worsening symptoms, severe hypotension, a weak and very rapid pulse, muscle incoordination, cardiovascular collapse, respiratory depression, convulsions, coma, and death.
How is it diagnosed quickly?
Clinically, the constellation of signs is suggestive. A diagnostic test can involve giving a small dose of a cholinergic agonist like methacholine or an anticholinesterase like neostigmine. In a poisoned individual, these drugs will fail to produce their usual muscarinic effects like sweating, salivation, slowing of the heart, because the receptors are already blocked by the atropinic agent.
And management.
Primarily supportive. If ingestion was recent, gastric lavage might be attempted, sometimes using tannic acid solution to help precipitate the alkaloids. Activated charcoal can help absorb remaining drug in the gut. It's crucial to manage the hyperthermia, keep the patient cool with cold sponging or cooling blankets. They should be kept in a dark, quiet room to minimize sensory input that could worsen the delirium and agitation.
What about a specific antidote? Physostigmine.
Vasicoselective is an anticholinesterase that can cross the blood-brain barrier, so theoretically it can reverse both the central and peripheral effects of atropine poisoning by increasing ASH levels to overcome the competitive blockade.
But is it recommended?
Generally, no, or only with extreme caution in severe cases by experts.
Ugh.
The problem is that physostigmine itself can cause significant toxicity, including seizures, severe bradycardia, heart block, and even a systole. The risks often outweigh the benefits, especially since most patients recover well with good supportive care. Diazepam can be used carefully for convulsions, and respiratory support might be needed.
Okay, so supportive care is key. What about contraindications for using atropinic drugs therapeutically? When should they absolutely not be used?
The main absolute contraindication is in patients known to have narrow-angle glaucoma or a predisposition based on a shallow anterior chamber. The mydriasis caused by anticholinergics can physically close off the drainage angle and precipitate an acute, vision-threatening attack of angle closure glaucoma.
And situations requiring extreme caution.
The big one is in elderly males with benign prostatic hypertrophy, BPH. The drug's effect of relaxing the bladder detrusor muscle, combined with potential pre-existing obstruction from the enlarged prostate, significantly increases the risk of precipitating acute urinary retention, a painful inability to void.
Good points. Let's finish with key drug interactions. How can anticholinergics affect other drugs?
One mechanism is by altering absorption, because atropine slows gastric emptying.
It usually slows down the absorption of other drugs taken orally.
Generally, yes. They just sit in the stomach longer before reaching the small intestine where most absorption happens. This can be particularly bad for drugs that are unstable in acid or need rapid absorption. For example, it can decrease the bioavailability of levodopa by allowing more peripheral degradation before absorption.
Are there exceptions?
Interestingly, yes. For a few drugs, like possibly digoxin or tetracycline, slowing down transit through the GI tract might actually increase their overall absorption by allowing more contact time with the intestinal mucosa. But generally, slowing is the main effect.
What about other interactions?
Antacids can physically interfere with the absorption of oral anticholinergic drugs, so they shouldn't be taken at the exact same time.
The most important interaction is probably additive effects.
Absolutely critical. Many drugs from different classes possess secondary anticholinergic properties. Think of older antihistamines like diphenhydramine, tricyclic antidepressants like amitriptyline, some antipsychotics, phenothiazines, antiarrhythmics like disopyramide, even the opioid peptidine, meperidine.
So combining these with a primary anticholinergic, like atropine or oxybutynin,
leads to additive anticholinergic burden. The side effects stack up increased risk of dry mouth, blurred vision, constipation, urinary retention, confusion, delirium, especially in the elderly. This is a huge potential pitfall in polypharmacy.
Any other specific interactions noted?
MAO inhibitors can interfere with the metabolism of some tertiary amine anticholinergic drugs used for Parkinsonism, potentially leading to CNS toxicity like delirium.
Let's tie this back to that implicit case study. The elderly man with BPH who starts an anti-vertigo drug and develops urinary retention.
That scenario perfectly illustrates the additive effect and vulnerability. The anti-vertigo medication was likely dimenhydrinate, Dramamine. Dimenhydrinate is an antihistamine, but it possesses significant antimuscarinic activity. That's part of how it works for motion sickness vertigo.
So in this elderly gentleman already predisposed due to his enlarged prostate,
adding the dimenhydrinate with its M3 blocking effects relaxing his bladder wall was enough to tip the balance. It pushed him into acute urinary retention. A classic example of understanding the hidden anticholinergic properties of common drugs and patient vulnerability. Hashtag tag outro.
And that brings us to the end of this incredibly detailed deep dive into anticholinergic and ganglionic pharmacology. We've journeyed from the natural alkaloids like atropine and hyoscine, really unpacked the critical roles of the M1, M2, and M3 receptors.
And see now, understanding their location and function is the absolute key to predicting drug actions and side effects. We move from the non-selective prototype to highly targeted agents, quaternary compounds for peripheral effects, inhaled drugs like tiotropium for the lungs, vasicoselective agents for the bladder, even partial agonists like varenicline for smoking cessation.
For you, the listener aiming for that professional mastery, the core takeaways are really understanding that receptor map, grasping the concept of the sensitivity gradient, and appreciating how subtle structural changes, like adding a quaternary charge, can completely reshape a drug's clinical profile and utility.
Exactly. Anticholinergic pharmacology is a fantastic illustration of how basic receptor science translates directly into clinical practice. Knowing why a drug works, based on its receptor interactions, allows you to use it more safely and effectively. Every side effect is just a pharmacological action in an unintended place.
So for our final provocative thought, building on what we learned, we saw how acute, complete ganglionic blockade dramatically reveals the dominant autonomic tone of each organ. Nicotine, from chronic tobacco use, provides sustained, low-level N-sub and S-sub receptor stimulation, potentially leading to subtle desensitization or modulation over time.
Right. So beyond the obvious risks of cancer and lung disease and beyond addiction itself, what are the long-term, perhaps insidious consequences of this chronic, low-grade chemical manipulation of the entire autonomic nervous system's balance point? Particularly thinking about systems heavily reliant on fine-tuned autonomic control, like microvascular blood flow regulation, immune responses, or even gut function over decades.
It suggests a much deeper systemic physiological disruption than just the acute effects we often focus on. Something for you to continue exploring.
Keep connecting those pathways and receptors.
Thank you for joining us on the Deep Dive.